already described about the pre-hospital management of the burns. Now it is in the intra-hospital management of the burns. So as I told you, once a patient is shifted to the hospital, it is always the airway which assumes the prime importance. And only when the airway is secure, you go to breathing. And only when the breathing is secure, you go to circulation. So, as a part of the inhalational injury, airway and breathing, whatever I told in the morning about the management of airway and breathing, that will apply to all the burn cases in general. So, it is the circulation that is of prime importance in this structure. And after circulation is managed, it is the pain, and then it is the infection control, and then it is the feeding, nutrition control. So, when it comes to circulation, it is to restore the volume of the fluid that is lost. So, to restore the volume of fluid that is lost, you need to understand what is the volume of fluid lost. So, the volume of the fluid lost depends upon the total body surface area. Now, how to calculate this total body surface area? The simple rule, if it is a smaller burn area, would be a palm. So, the palm with an extended finger contributes to about 1% of the total body surface area. So it is 1% of the body surface area. If four palms are there, 4%, five palms, 5%. It is a palm of the patient with extended fingers. But if wider areas are involved, what we use is Wallace rule of 9. Clinically, Wallace rule of 9 is used, which tells that the head and neck of the patient and the right upper limb and the left upper limb, each of them are 9% of the total body surface area, right? Which contributes to 9 3 27. Right. I request whoever has the video on, kindly switch it off, and you can keep it on when you are talking. So the head and neck, the right upper limb and the left upper limb contribute to about 9% of the total body surface area, while the anterior chest, the posterior chest, the right lower limb and the left lower limb, all of this contribute to 18% of the total body surface area. So which is together 18 4 just 72, and this contributes to about 99% of the total body surface area. And this 99% plus 1% of the genitalia plus the perineum. So this is Wallace rule of 9. But in case of a child, the head and neck assumes 18%. When it assumes 18%, it is 9% extra, which is taken away from the each lower limb. So the right lower limb becomes 13.5%, and the left lower limb becomes 13.5%. And this extra 4.5, 4.5, which together is 9%, is added to the head and neck to contribute it to 18%. This is crude method of estimating. If you want more accurate methods in adults, you can use a Lund and Broder chart. Or in case of children, you can use a Perco chart, which are commercially available charts. Right. So either it is by using the rule of palm or the Wallace rule of 9, and the in case of adults, Lund and Broder and child Perco charts. These are more sensitive charts and more acute estimation of the total body surface area involved will be gotten by this. So once you calculate the total body surface area, then you need to resuscitate with fluids. So what fluids you give can be a crystalloid, it can be a colloid. As I told in the morning, in a burn patient, there is increased vascular permeability. This increased vascular permeability will cause the exudation of whatever substance is present in the blood into the surrounding tissue. So if a colloid is given, all this colloid will go into the surrounding tissue. And this is maximum in the first 24 hours. That is why the colloids are usually not preferred in the first 24 hours, because whatever you give, these colloids will extravasate into the third space, and in the interstitium, these colloids start accumulating fluid in the interstitium that will actually exacerbate the tissue edema and the hypoxia. That is why they are not prescribed. But the newer studies tell that they can be started anywhere between 8 to 12 hours. Right? But before 8 hours, it is an absolute contraindication. 8 to 12 hours, they can be given, but better to give it after 24 hours. And when you give a crystalloid, it can be a isotonic solution or it can be a hypertonic solution. Now, when you give a hypertonic solution, it is a hypertonic normal saline, which is a 5% hypertonic normal saline. The advantage is that because it is a hypertonic solution, it will draw all the fluid from the periphery into the blood vessel. So when the fluid from the interstitium is drawn into the blood vessel, one is it will maintain the blood volume. Second, it draws the fluid from the periphery, it will reduce the tissue edema. When the tissue edema reduces, it will reduce the laryngeal edema. When the laryngeal edema reduces, the need for intubation reduces. Also, it reduces the need for escharotony. So, because of the fact that it is hypotonic, it reduces all these things. But the problem is that you give more of this hypotonic saline that will increase the sodium levels and it leads to hypernatremia. So, while you are giving a hypotonic saline, make sure that you maintain the sodium levels to less than 160 milliequivalent. Right? Up to 160 can be tolerated. But the ideal fluid is always a isotonic crystalloid, which is RL. So RL is the fluid of choice in case of adult. But if there is a child of less than 2 years of age or any patient less than 30 kg, these patients do not have adequate glucose reserves. So children do not have adequate glucose reserves. Adults can have fat and protein, they can mobilize these reserves, but a child of less than 2 years cannot mobilize these reserves, and a patient of less than 30 kg does not have any reserves at all. So for these patients, you need RL plus 5% dextrose, right? So RL is the fluid of choice in resuscitation in general. But if a child of less than 2 years or any patient of less than 30 kg, RL plus 5% dextrose is the fluid of choice. So this is the choice of fluid that you need to give. And a colloid can be a human albumin or it can be a FF. Now there are various formulas for calculation of this fluid, how to give. So the formula for crystalloid is a widely used formula, is a Parkland formula. So Parkland formula is 4 ml of fluid is given for every kg of the body, which is multiplied into total body surface area. In all the patients, the total body surface area is considered to be 50% maximum, right? Because once 50% is involved, the rest of the fluid gets accumulated in the non-burnt tissue. And giving more of the fluid is neither beneficial, and second is it will cause lead to ARDS. So that is why the 50% body surface area is cut off. Even if it is 60, 70, 80% body surface is involved, we take a cutoff of 50% only. So it is 4 ml per kg, which is Parkland. According to Bailey 28 edition, modified Parkland is also 4 ml per kg body surface area, right? And there is something called as Berklow formula, which is 2 ml per kg body weight into total body surface area. And for children, the kg better than kg, the body surface area of child is taken into consideration. So there is a Galveston. This is for a child. So according to Galveston, it is 5 liters per the total body surface area of the burns. So whatever the burns is involved, that is the total body surface area of every meter square of the burn. You give 5 liters. Along with that, 1.5 liters for the body surface area of the child. The body surface area of the child for every meter square of the body surface area of the child. Obviously, it will be less than 1 meter square. It will be in points. So it is 1.5 liter per body surface of the child plus 5 liters for the total area of the burns which is involved. And if it is an electrical burn, it is always better to give 4 ml per kg. This will talk later when it comes to electrical burn, because in electrical burn, the amount of skin involved is less compared to the internal damage. So the most common organ that is involved in burns, as we discussed in the morning, is skin, because it is the largest organ and the organ that comes in contact with the burn first. But electrical burn, the amount of damage depends upon the resistance. The skin and bone offer greater resistance than the underlying muscle, nerve, or a tendon. That is why the skin is not as much damaged as the muscles and bones are damaged. That is why we take total body surface area of the skin involved. We can underestimate the amount of damage that has happened. That is why in electrical burn, it is always 4 ml per kg body area. And in case of pediatrics, if you are not able to calculate this Galveston, try to give 3 ml per kg into total body surface area of the burns. In all these formulas, when you calculate the total fluid, it is divided into first 8 hours and next 16 hours from the time of burn. From the time of burn, within 8 hours, you complete 50% of the fluid because that is the area of maximum increased vascular permeability and maximum loss. And in the next 16 hours, you complete the rest 50% in whatever formula you use. The most common used is this 4 ml per kg and 3 ml per kg in case of a child. Right. So this is about a crystal. When you want to give a colloid, as I told you, colloids are not generally preferred within 24 hours. But if you have to give, you can start it anywhere after 8 hours. So here the colloid is either a human albumin or FFP is used, and it is calculated according to a formula called as Muir and Barclay formula. Now this Muir and Barclay formula tells that you take a fluid of 0.5 ml per kg of the body weight and multiply it to total body surface area. Whatever you get is one portion. You give it as 6 portions. After 12 hours of the burn injury, you start this colloid. For you divide into first 4, next 4 hours, then 6 hours, then 6 hours, then 12 hours. Right? You give it into 6 portions. So one portion, one portion, one portion, one, one, one. So if the patient is about 50 kg and body surface area is around 20, which is inward, so it will be 50 into 20 into 0.5, which is half. So it would be 500 ml. So this is one portion. So first 500 ml you give in first 4 hours, and again next 4 hours 500 ml, next 4 hours 500 ml, next 500 ml in the 6 hours, next in the 6 hours, next in the work period of 12 hours. So this will be around 36 hours. So 6 portions of fluid of 0.5 ml per kg of our body surface area is given over a period of 36 hours. So once you give this, you need to see the adequacy of the fluid. So the adequacy of the fluid, the pulmonary capillary wedge pressure is better than the CVP, right? So you need to keep the pulmonary capillary wedge pressure in the range of 12 to 15 mmHg, and CVP has to be kept to more than 8 mmHg, right? If these cannot be measured, you measure urine output. In case of an adult, the urine output has to be maintained in the range of 0.5 to 1 ml per kg per hour. In case of a child, the urine output has to be maintained to 1.5 to 2 ml per kg per hour. But if it is an electrical burn, it is imperative that you maintain fluid to 2 ml per kg per hour. So this is how you need to assess the adequacy of the fluid resuscitation. Once this is achieved, then you need to put the patient onto a maintenance fluid. So once you resuscitate these patients, you need to put these patients onto a maintenance fluids. So these maintenance fluids can be either RL, now you can use a DNS along with that, or you can add a 10% dextrose. These maintenance fluids are given by the formula of a Holiday cigar. So according to Holiday cigar formula, for first 10 kgs, you need to give 100 ml per kg per day. For next 10 kgs, so this is 0 to 10 kg, this is 10 to 20 kg, you need to give 50 ml per kg per day. And for next 10 kgs, you need to, for after 20 kg, for each kg, you give 20 ml per kg per day, right? So it is 100 ml per kg per day for 10 kgs, and 10 to 20 kgs, it is 50 ml per kg per day, and rest all after 20 kgs, it is 20 ml for each kg. So if the patient is 70 kg, so you can divide it into 10 kg, 10 kg, and then 50 kg. So this 10 kg would be around 1000 ml. Then this would be around 500 ml. Then it would be around 50 into 20 would be around 5 to the 10. Again 1000 ml. So it would be around 2.5 liters of fluid per day is to be given as a maintenance fluid. Now remember, do not confuse it with what I told in the shock. In the shock, the maintenance fluid, what I told was 10 ml per kg per hour, which is then, sorry, 4 ml per kg per hour, 2 ml per kg per hour, and then 1 ml per kg per hour. It was with respect to hour. This is with respect to day. So this is a Holiday cigar formula, which is widely used formula to have a maintenance fluid. Okay. So this is about the fluid resuscitation and the circulation in general. Is this understood? Hello, hello. After fluid, it is the pain control. So I told you always for pain control, it is IV, intravenously you need to give, because when you give an IM injection or a subcutaneous injection, because in burns there is hypovolemic shock, and whenever there is a shock, what body tries to do is it shunts the blood supply. So all the blood from the skin, from the subcutaneous tissue, from the muscle is shunted to the vital organs like brain, heart, and kidney. So this happens because of a preferable vasoconstriction in these areas and vasodilation in these areas. So when you give a drug in a IM route or a subcutaneous route, because there is a vasoconstriction, the patient does not, this is not absorbed into the systemic circulation and the patient does not have pain relief. This is first. Second is, as you resuscitate the patient, there is a good amount of volume of the blood in the patient. This vasoconstriction will eventually lead to vasodilation. The blood vessels dilate because there is no need for shunting of the blood anymore. Now you have given this drug for 3 days, BD, IM. This was not absorbed there. Now 6 times the drug will get absorbed into the IV. Now that produces the toxic effects of the drug. So these are the two reasons why you need to avoid IM injections and always give IV injections, right? So IV opioids are the drug of choice in patients for pain control. After you control the pain comes the wound management. In the morning, we had discussed about the types of the wound depending upon their severity. So it is a superficial wound, a superficial partial thickness wound, a deep partial thickness wound, and a full thickness wound. Now, these wounds, as I told you, superficial wound and a superficial partial thickness wound have some amount of the epidermal elements present with them, or there is a epidermal elements in the rete ridges or in the dermis or in the hair follicles or in the sweat keratinocytes where they can heal themselves by epithelialization. These deep partial thickness wounds and full thickness wounds cannot heal by themselves. When these heal by themselves, our only aim in this treatment is to prevent the further infection and give adequate moisture so that these wounds will heal. But these wounds need graft or a flap for their reconstruction because the dermis is gone, subcutaneous layer is gone, muscle is gone, sometimes even bone is gone. So that is why you need a graft or a flap. That is why these are classified as group A wounds and these are classified as group B wounds. Right. So group A wounds are those wounds which heal spontaneously that include a superficial wound and a superficial partial thickness wound, and they do not require any further grafting or flap placement. We just need to maintain the wound without getting it contaminated. But the group B wounds eventually need excision of the eschar and a grafting or a flap. So these group A wounds as a superficial wound or a superficial partial thickness wound. A superficial wound needs only topical ointment. It does not even need a wound coverage. You don't cover the wound. If it is a superficial burn, which is limited to epidermis, you just apply a topical ointment and leave it off. You don't need to dress the wound. But a superficial partial thickness wound always needs a dressing. Now, there are various types of dressings available for the burn wound, which is a again a question in the recent advances, right? So, the dressing of the burn wound is a question. We'll discuss it in a other class where We'll also take into consideration about various wound dressings. Right? So now, for now, we'll focus on the Group B wounds. So Group B wounds need surgical management. Now, this surgical management is essentially a SCHAR routine. Right? So SCHAR is a charred, insensitive, denatured skin, which is formed over either a deep partial thickness wound or a full thickness wound. It is actually because of the coagulation of the proteins, which will protect from further damage to the cell. But this SCHAR can get infected and can lead to the sepsis and delayed complications. That is why there is no point in keeping the SCHAR. So once SCHAR is formed, it has to be excised. So when it comes to escherotomy, there are two schools of thought. One is early excision of eschar, and the second is staged burn excision. If the patient comes to you early and the facilities are available, it is always better to do escherotomy. So as soon as the patient comes, it is if the facilities are available, it is better to do escherotomy. And the best results are obtained if escherotomy is done within 48 hours of the injury. Why it is good is first is, as I told you, it takes 4 hours for the laryngeal edema to set in. And if the burn is in the upper extremity, you need general anesthesia with endotracheal intubation. Once laryngeal edema sets in, it is difficult for endotracheal intubation. So that is why the early escherotomy will give you a anesthetic window. So if it is within 4 hours, it is easy for intubation. Second is after 48 hours, the blood vessels start to dilate and there is vasodilation. This vasodilation will result in blood loss. The blood loss from the shock chapter, you know that any blood loss will again lead to acidosis and coagulopathy, hypothermia, right? The lethal period of the death. So that is why there will be more bleeding. But if you can get it done within 48 hours, so there is less vasodilation and therefore there is less amount of the bleeding. So this is called as hemodynamic window. And the third thing is when the patient has developed SCHAR, even if this SCHAR gets infected, the infection is localized to the burnt area only. But you leave it for a longer time, this infection will spread into the blood vessels and it leads to the systemic inflammation. So that is a septic window. You get a septic window where the infection is limited only to the burnt area and not a systemic spread of the infection. And fourth is because the vasodilation has not yet happened, the tissue edema is relatively lesser, right? Because tissue edema is lesser, hypoxia is lesser, and tissue planes are better compared to the late excision. So that is why you get an anesthetic window, you get a hemodynamic window, a septic window, and there is less tissue edema. That is why it is better to do escherotomy as soon as possible. Early SCHAR excision within 48 hours has got excellent results. But if the patient has present in a delayed fashion, or if the immediate facilities are not available, or if the patient's status is not good that he can be taken for a operative procedure. If you cannot tolerate operative procedure, then you can do a staged burn excision. But the problem with staged burn excision is once it crosses 48 hours, there is more bleeding. And the more you remove, there is increased risk of hypothermia. So when there is more bleeding and more risk of hypothermia, you need to cut down the amount of tissue that you can excess. If the patient has presented early, you can remove 100% of the SCHAR. But if the patient has presented late and you plan to do a burn excision, every time you do a burn excision, you just remove 20% of the SCHAR. And next time you remove 20%, the next time you remove 20%. So that is the concept behind a staged burn excision. So any patient coming to after 48 hours, better to plan a staged burn excision. But if you can get it within 48 hours, early complete excision is advisable. This is about the two strategies. Now, what are the principles of this escherotomy? Now, escherotomy has to be done. The first principle is under adequate anesthesia because already the patient has got lot of pain And if adequate anesthesia is not there, you cannot have, there is an increased surgical stress response. It will again worse the things from the surgery. So adequate anesthesia and adequate temperature control is very important, because hypothermia leads to acidosis, coagulopathy, increased blood loss, all the cycle of the events. Right? So adequate anesthesia and adequate temperature is important. This is first. Second is, how do you plan these incisions? So if it is on the chest, there are three ways where you can give a escharottomy over a chest. So the first thing would be a midline incision is given and it is extended onto the either sides below the nipple. So this is one way. The second way is that you can give two lateral incisions like this. This is the second. And the third way is a C and a reverse C shape incision. So if this is the chest and these are the clavicles, so you can start an incision underneath the clavicle, go it along the anterior axillary line and terminate at the inframammary area. And here on the same. So these are the three ways by which you can give a escharottomy over the chest. This is first. If it is in the abdomen, so the best incision for the abdomen would be a incision which is parallel to the bilateral subcostal margin. So this is the incision for the abdomen. And on the limbs, it is always better to give a mid-axial incision, right? So mid-axial incision is you give an incision here, right, in between the anterior and the posterior aspects layer. So you give a mid-axial incision on the limb. You give it both on the medial aspect and on the lateral aspect. And in the elbow, it is always anterior to elbow, because posterior to elbow on the medial aspect, there is a ulnar nerve. You preserve the ulnar nerve, given incision anterior to the elbow on the medial aspect, on the lateral aspect, mid-axially, in between the anterior and the posterior parts. And when it comes to thenar eminences, so when it comes to the hand, you extend the incision over the hypothenar eminence and over the thenar eminence. And when it comes to the digits, you give an incision on the either side of the digits. So you do an incision on the either side of the digits. And when it comes to a lower limb, in the lower limb is again a mid-axial incision. So it is between the anterior aspect and the posterior aspect, one on the medial side and one on the lateral side. On the medial side, you always give posterior to medial malleolus, because anterior to medial malleolus, there is a great saphenous vein. And on the lateral aspect, you give anterior to fibula, right? Because posterior to fibula is a common peroneal nerve. Right? So these are the things. So the plan of the incision should be such that you give longitudinal and adequate escharottomies. Right? And the fourth is you should preserve the neurovascular bundle. Right? We should preserve a neurovascular bundle. So that is why you give these incisions. Right? In the upper limb, it is in the chest, there are three types of incisions which can be given. In the abdomen, it is the bilateral subcostal incision. In the upper limb, mid-axial incision, anterior to elbow to preserve the ulnar nerve, and you extend it onto the thenar and the hypothenar eminence. On the digits, it is on the two lateral aspects of the digits. In the lower limb, it is again a mid-axial incision. In case of medial side, it is posterior to the medial malleolus, because anteriorly there is a GSV, and on the lateral aspect, it is anterior to the fibula, because posteriorly there is a nerve, common peroneal nerve. And once you do this excision, it has to be always adequate. Adequate meaning the length of the eschar should be greater than the length of the eschar should be greater than the length of the eschar, and it has to be deeper than the depth of the eschar. And you need a immediate cover. If you have planned a complete escherotomy, you can cover it with a skin graft. If you have not planned a complete, if there is only 20% of the eschar that is removed, you need to cover it with an antibiotic soaked dressing. And post-operatively, you need to put the limb in elevation, and you need to put the limb in, splint the limb in position of function. Right? So what it means is, for You see the burn patients when they develop SR and that is not treated, you can see that the patients are unable to extend their knees because in lower limbs the contracture produces a flexion deformity. And in the upper limb, most of these patients will not be able to abduct their hands because the area, the pectoralis major and the deltoid muscle where they join, it gets contracted, leading to the adduction deformity. So always the lower limb has to be put in extension. You splint the lower limb in extension position and you splint the upper limb in a abduction position. So these are all the principles of the escherotomy. You have to get a adequate anesthesia with adequate temperature control. You plan the incisions in such a way that it is long and adequate of depth and it does not injure the neurovascular bundles, and you try to immediately cover it either in the form of a skin graft or in the form of a antibiotic soaked dressing, and post operatively you give elevation to the limb and you splint the limb in a position of function. Now when you do this excision, how to do this excision procedure? So under adequate anesthesia plus temperature control, you first subcutaneously inject adrenaline, which will control the bleeding, which is of 1 is to 5 lakh or 1 is to 10 lakh adrenaline solution is taken and it is injected subcutaneously. Once you inject it subcutaneously, you do a excision. Now, excision, the most preferred is a tangential excision. Tangential excision means if this is an eschar which is formed over a skin, you just take it out parallel to the skin. Right? You take a knife and you keep the knife parallel to the skin and you remove the eschar. And you keep on taking it out in layers until you see a punctate bleed. Right? A punctate bleed is a good sign that adequate escherotomy has been done. But if the body surface area is involved to less than 40% and it is a deep wound, then you need to completely excise. But even though if it is a deep wound, but the body surface area is more than 40%, you cannot excise such an amount of wound. That is why you need to do a tangential excision. So always tangential excision is preferred. But if there is a deep wound and the amount of involvement is less than 40% of the body surface area, you can do a tangential excision. So after you do this excision, again there will be bleeding. So you control the bleeding with topical adrenaline now. So before excision, you give a subcutaneous injection of the adrenaline. Now you give a topical adrenaline of 1 is to 5 lakh. Now this wound, if you plan for a early eschar excision, which is complete excision of an eschar, you put a graft immediately. Right. So this early eschar excision and graft has greatly reduced the mortality and morbidity in burn patients. So this is preferred. But if for any reason you could not do a complete excision, you plan for a staged burn excision. So then you dress it with an antibiotic cover. Post operatively, you elevate the limb and you put the limb in position of function and you start active physiotherapy on POD5. Right? For 5 days, you keep the patient in a position of splinting and you start on active physiotherapy on the POD5, and then later, depending upon the wound condition, you can take for serial debridements. Now we'll talk about this graft. So when you want to put a graft to these patients, once you do a complete excision, you need to put a graft. So you can put a graft, and this is very good because it reduces the sepsis and mortality and morbidity associated with the burn. So we have the full thickness graft and a split thickness graft. So this is again a separate class. It is too extensive, but I can tell you in short that whenever a large areas of burn is involved, a surface needs to be grafting, it is better to take a full thickness graft. It is cosmetically not good because the graft has a secondary contracture because it does not have any dermal elements. And the cosmetical outcomes become further diminished depending upon the meshing. The greater meshing we do, the greater is need for the contracture and greater will be the cosmetic deformity. So that is why when you graft, it is obviously a split thickness graft, which because a full thickness graft cannot be given for a such large area. If the burn surface is very small, if it is a deeper wound, full thickness graft can be taken. But most of the times, burn surface area is too wide and you put a split thickness graft. And this is obviously an autograft. You do a autograft with a split thickness graft, but you do not mesh it, right? Because mesh will further increase the contractility. But because you do not mesh it, that can lead to a seroma formation, or it can not cover the area adequately because mesh expands the graft. So that is why even if you want to mesh, the better option would be to mesh in the ratio of 2 is to 1. So second is, if the area is too wide and the mesh needs a greater meshing, you cannot have this autograft alone to cover such a huge area. So in such conditions, you can have this autograft. Along with that, you can put a cadaveric allograft. Right? I'll explain it. So if this is the total amount of the burn surface area that is involved, you have excised it completely and you need to cover it with a graft. But the graft is not adequate. So what you do is you cover this area with a graft with wider meshes. So you take it a 4 is to 1 ratio of a mesh. So when you cover it with wider meshing, this area is covered with skin and this area has a fenestration. Here there is skin and then there is fenestration. So then there is fenestration here, there is skin, fenestration, skin. So similarly here there is skin, fenestration, skin and fenestration. Now these fenestrations will lead to the either they do not develop a granulation tissue or either they do not epithelialize or they develop lot of contracture. So to prevent that, what you do is you take a cadaveric allograft and you put it onto this already grafted skin with a ratio of 2 is to 1, which are a smaller meshes, right? It is like putting two meshes, one with a wider hole, and upon that it is a mesh with a smaller hole, and this cadaveric mesh will cover the allograft or the autograft which is kept inside. So this will heal within 21 days, and this cadaveric allograft will fall off. Even after using this cadaveric allograft also, sometimes if the body total body surface area is more than 60-70%, you do not get adequate coverage. Then what you can do is you take cultured epithelial autograft, CEAG, which is you take a full thickness biopsy from a cell, from an area, and this full thickness biopsy will produce the keratinocytes. There are keratinocytes which are present. You extract these keratinocytes from the full thickness biopsy and you culture them in the lab. And once you culture them in the lab, they will produce a graft. And this graft can be used to cover more than 80% of the total body surface area. So that is why it is useful. Cultured epithelial autograft can help you to cover more than 80%, which are the keratinocytes taken from a full thickness biopsy. A small full thickness biopsy can produce a large graft which is present. But the disadvantage is that for that to get cultured, it will take at least 2 to 3 weeks. So again, the concept of early excision becomes waste because you excise, but there is no graft. Now again, it is prone for developing the infection. So it will take 2 to 3 weeks. Second is this is costly and is not available in all the settings. The third is this is purely keratinocytes which are extracted from a biopsy. There is no dermal element because there is no dermal element and this produces severe scarring. Right? That is the difference between a split thickness and a full thickness. Full thickness produces less scarring because there are dermal elements. And a keratinocyte obviously has no dermal element. It is a single cell that is producing a epidermal skin. That is why there is a lot of scarring in these patients. And the fourth is it can predispose to squamous cell carcinoma, right? So it takes a longer time, it is costly, it produces scarring, it can predispose to squamous cell carcinoma, and it is less strong and can be easily disrupted by a shearing force. So the graft, if there is a mechanical trauma, the graft can get easily disrupted. And to prevent scarring, you can add a dermal elements, right? All these are producing scarring, but you want to prevent scarring, but these do not contain the dermal elements. You can add a dermal element to that. That is what is Integra, right? So Integra is a biosynthetic graft that gives a dermal element, which can be used so that it reduces the scarring. So these are the various types of the grafting that is available once you excise a burn wound. But there can be a graft failure also, especially in a burn case. This can be a graft failure. Now, this graft failure happens first is if there is inadequate eschar excision. You do not excise the eschar adequately, this will lead to the inadequate eschar excision. So, adequate eschar excision is still you see a punctate bleed if it is tangential. And second is if there is a shearing force. Okay. So, shearing force will take the graft away from the bed, right? So to prevent that, you need to always splint. Wherever you put a graft, you need to splint the limb based on a position of function. And certain areas, like if there is a buttock, there's a wound or a buttock, you cannot splint the buttock. So in such areas, you need to do a kilting sutures. So kilting is you might have heard this word while making beds, right? A plain bed is just like this, but you make suturing in this bed will assume a honeycomb appearance, right? So this honeycomb mattress is called as a kilted mattress. So similarly, when you apply a graft, in the center of the graft, you take a absorbable sutures so that you kilt it. So you fix the graft to the underlying skin in the center at multiple areas by kilting. So either you put a splint or you put a kilt so that the shearing forces are reduced. And the third is there can be infection. So any patient who has got a total body surface area of more than 30%, you start him on perioperative antibiotics. Right? So at this point, I want to tell you guys, even in the lung infection, inhalational injuries, there is no role for a prophylactic antibiotic. You give a prophylactic antibiotic only when the bronchopneumonia is established, as we discussed in the morning. The second point is the peripheral antibiotics, the prophylactic antibiotics are also not indicated in case of a burn wound unless the total body surface area is more than 30% or the colony forming unit is more than 10 to the power of 5 per gram of the tissue. So you take a gram of the tissue, send it for culture, it is more than 10 to the power of 5 of bacterial load or the total body surface area of more than 30% is involved, these are the indications for a prophylactic antibiotic. If not, there is no reason to start a prophylactic antibiotic in a burn area. So this is all about the wound management in the burn. So there is that dressing is left. So I will tell that along with the recent advances in the burns. Is this clear? Hello.
Yes, sir.
So after this, the next important topic is nutrition. So at this stage, I want you to guys understand about hypermetabolism. We have a chapter on this metabolic response to the stress. So these are all the pathophysiological responses, the understanding of which will help us to take clinical decisions for management. So every aspect of nutrition and fluid management is as vital as a surgical aspect for a clinician. So hypermetabolism can occur in any severe injury. So if the patient has undergone a severe surgical stress, there is a major operation which is done, or the patient has a major trauma, he is recovering from that, or the patient has got a severe sepsis, or the patient is in burns, any of this severe state can lead to hypermetabolism. So if you look at metabolic response to an injury, the body actually responds in two phases. One is the ebb phase, which gets converted into a flow phase. Right? So in the ebb phase, the body has to conserve the energy. That is why it reduces the cardiac output and it reduces the oxygen consumption and oxygen delivery. It reduces the basal metabolic rate. This is in the ebb phase so that the body has to conserve the whatever energy reserves it has left. But once you resuscitate these patients adequately, the patients are out of that critical stage of lethal triad of death and the patient have got blood and the adequate amount of volume flowing through the body and there is adequate tissue perfusion of the periphery, the patient slowly switch into the flow phase. And the initial part of this flow phase is the catabolic phase. So this catabolic phase is characterized by increased cardiac output, increased heart rate, increased oxygen consumption. Because the oxygen consumption is increased, there is increased delivery of the oxygen and it is increased BMR, and it is associated with massive proteolysis and lipolysis. Right? Now, this catabolic phase of the flow phase is called as hypermetabolic phase or the hypermetabolism. Now, later, these patients go into a anabolic phase where these patients start to slowly recover from the injury, and there is small amounts of proteins and lipids in the body keep on increasing, but this can take from several months to several years. So whenever the patient has gone this severe trauma or a surgical stress, the patients can remain in the catabolic state for a prolonged period of time. That is one of the reasons for the patients to deteriorate in the postoperative phase. And the anabolic phase can start, it can take months to years to start. And once it started to get completed, also it can take years. Now, all our efforts in the postoperative management of the patient is to reduce the catabolic phase as much as possible so that we put the patient into the anabolic phase as early as possible. Now, this can happen in any surgical stress, but it is most profound in case of a burns. The reason is that I told you in the morning that as soon as there is a burns, 80% of the genomes in the circulating inflammatory cells get altered. There is a lot of massive and dramatic inflammatory response in the body, and this is called as genomic storm. 80% of the genes of the circulating cells get altered so that there is a massive inflammatory response. And along with that, you might have observed if the patient had got a trauma, if he has got splenectomy, he may be immobile for 3 to 4 days, and as soon as he recovers from the shock, he will be mobile. And if the patient has severe septic shock, as soon as he recovers from the shock, he will be mobile. But a burn patient has got a prolonged bed rest, and we put all the things, all the limbs into the splint. So that is why there is bed rest and immobilization. So this prolonged inflammatory response or dramatic inflammatory response along with a prolonged bed rest and immobilization contribute to the dramatic hypermetabolism. So this is most dramatic in a patient with burns. Now what happens is in this phase, there are three important hormones that are released. One is a catecholamine, which includes the adrenaline, noradrenaline, and dopamine. The second is a cortisol, which is glucocorticoids. And the third hormone is the insulin glucagon ratio. So now what catecholamine does is this catecholamine has receptors all over the body. It has got a alpha receptor and a beta receptor. Now this has a direct action on a myocyte, which is a muscle cell. It has an action on a lipocyte or a adipocyte, which is a fat cell, and onto the hepatocyte. Now, on the myocyte, it causes proteolysis, and on lipocyte, it causes lipolysis. And it uses this proteolysis and lipolysis as a substrate to produce glucose from the liver by hepatic gluconeogenesis. So, new glucose is produced by using the proteins and the lipids, the products of the proteins and the lipids. This is a direct action via the alpha and beta receptors. Now, this also has an indirect action. Indirect action is again through alpha and beta receptors, but it is through the pancreas. It via beta receptors, it stimulates the production of glucagon. It also stimulates the production of the insulin. But via alpha receptor, it selectively inhibits the production of the insulin. So glucagon production is inhibited, while the insulin production is inhibited by the alpha receptor. So when this happens, the glucagon in the blood becomes more than that of insulin. Now, as you know, this glucagon also causes glycolysis and increases the blood glucose level. All these things will also increase the blood glucose level. So there is a state of hyperglycemia. But this blood glucose level, there's a lot of glucose in the blood, but this glucose cannot be utilized by the cell because the peripheral resistance is increased by the third hormone, which is cortisol. So cortisol increases the peripheral resistance and induces a state of hyperglycemia. So that is why hypermetabolism is a state seen in patients after resuscitation in a severely injured patient with a severe toxic, severe septic septicemia or severe burns or severe trauma, which is characterized by increased heart rate, increased cardiac output, increased basal metabolic rate, increased energy expenditure, increased oxygen delivery, increased oxygen consumption, and massive proteolysis plus lipolysis. Right. So this is what is hypermetabolic state, and this is the mechanism through which it happens. So when there is a proteolysis, this catecholamine via the alpha and beta receptors act onto a myocyte and it causes proteolysis. Now this will produce loss of muscle. When the patient loses the muscle weight, there is muscle bulk and muscle undergoes atrophy, and the muscle which is atrophy cannot generate heat. So this that leads to hypothermia. When proteolysis happens, it is broken down into amino acids. 18 out of the 20 amino acid pool are glucogenic. So they will be led to form glucose via the hepatic neoglucogenesis. But some of these amino acids also enter the tricarboxylic acid cycle and they will produce ATPs. Some of the amino acids will enter into the liver but do not produce glucose, they produce acute phase reactants. So that is why even after the patient is recovered from the burns, we can still see that the CRP levels are elevated because it is an acute phase reactant because of the catabolic state of the body, and the fibrinogen is increased. The alpha 2 macroglobulin is increased and a complement is increased. So these are all the acute phase reactants which are increased because of the proteolysis. So this is what happens and it ultimately leads to the loss of the muscle. The second thing is this catecholamine acts onto the adipocytes or the lipocytes by the alpha and beta receptors and it causes the lysis of fat. So when the fat is lysed, it is divided into a fatty acid and it is divided into a glycerol. Now this glycerol is utilized to produce glucose, which will increase the blood glucose levels. This fatty acid is taken to the liver. This fatty acid can also produce uh, energy ATP, or this fatty acid can be taken up by the liver, where this fatty acid is re-esterified to produce triglycerides. These triglycerides will get accumulated into the liver and they will produce a fatty liver. So catabolic state can produce loss of muscle, it can produce a fatty liver, or it can be converted into LDL. When the levels of LDL increase, they produce cardiac issues. So because of this hypermetabolism, the patient has got a fatty liver, he has got cardiac issues, he has got loss of muscle, loss of metabolites, loss of these metabolites will also lead to significant loss of weight, and it will also lead to the derangement in the enzymes. And when enzymes get deranged, there is loss of immunity. When immunity gets deranged, the wound will not heal or there is sepsis. So that is why adequate nutrition plays an important role in a burn patient. So now when to start this nutrition? So initially, these burn patients have acute gastric dilatation, as I told you, and any food that is given to these patients, they are likely to aspirate. So you put an NG tube. But as soon as the gastric distension reduces, you start feeding. So always enteral feed is preferred over a parenteral feed because enteral feed will prevent the gut atrophy. That is why you always prefer a enteral feed. If the patient is taking orally, give him orally. If not, put a nasogastric or a nasojejunal tube and give a enteral feed. And the formula to give calculate calories in this patient is called as a Curer formula. So according to this Curer formula, you give 25 kilocalorie per kg weight of the patient plus 40 kilocalorie for the total body surface area that is burned, right? So if the patient is 70 kg and has got 40% of total body surface area, so it would be 70 into 25, which is which will be around 1750 kilocalories, and along with that 40 kilocalorie for 40% of body surface area, which is 1600. So total would be 750 1750 plus 1600, which is 3.3 kilocalories. So 3,350 kilocalories of the diet has to be given to the patient every day, right? This is how you calculate the nutrition in these patients. And along with this, you maintain the protein requirement to 1 to 2 gram per kg per day. So this is about the nutritional aspect of these patients. And the last part is to manage the complications. At this point, I want to tell you the most common cause of immediate death in a burn patient is asphyxia. The most common cause of early death in a burn patient is hypovolemia. And the most common cause of late death in a burn patient is sepsis. Now, because in the most of the patients we are able to manage asphyxia and hypovolemia, the most common overall cause of death would be sepsis with multi-organ dysfunction syndrome. MODS, more than one organ failure, is called as a multi-organ dysfunction syndrome. And the most common cause for sepsis is the tissue edema. So the tissue edema itself is the most common cause. And the second cause would be the lung infections. And the next would be a external devices like a Foley's catheter, a Ryle's tube, or a central venous catheter. So the most common cause is a tissue edema. And the most common organism is either Staphylococcus aureus or a group A beta hemolytic streptococci. Some tell us Staphylococcus aureus, some literature tell it is group A beta hemolytic streptococci, but it is a gram positive. So the most common gram negative organism is a Pseudomonas followed by Klebsiella. Right? So these are some of the things that you need to remember. Now, what are the complications and how to manage them? So first is pulmonary complications. I discussed about all these pulmonary complications in the morning in the inhalational injury. So we'll skip that. And the second would be a renal complication. Renal complication is one because of the oliguria, the patient has developed acute kidney injury, right? Or because of the myoglobin, the patient has developed acute kidney injury. Or the toxins themselves can produce acute tubular necrosis. So most of this resolve if you give adequate fluid resuscitation. Most of this will resolve. But if they do not resolve, there is persistent acute kidney injury, which according to a KDI Geo class, if it is more than 3, or if there is a persistent electrolyte abnormality, and the patient develops hypervolemia after resuscitation, which is not responding to diuretics, then it becomes an indication for hemodialysis, hemofiltration, or CRRT. Always CRRT is better to HD or HF, right? So if there's a persistent AKI so of class 3 and more, if there is a persistent electrolyte abnormality, and post resuscitation, if there's a hypervolemia which is not responding to diuretics, you put the patient onto the hemodialysis or hemofiltration or CRRT. Then next is liver. So if liver is involved, it is very important for the production of coagulation factors 2, 7, 9, 10, and that will lead to the coagulopathy. And you correct it by giving vitamin K injections, or you may need to transfuse the FFP also. As I told you, the gallbladder can be involved, and there is acute acalculous cholecystitis, right? In any patient who has got severe stress in the body, either in form of a burn or in the form of a severe sepsis, major trauma, these patients will develop a acute acalculous cholecystitis, so much so that these patients might need a percutaneous cholecystostomy. Doing cholecystectomy in these patients is detrimental. So in acalculous cholecystitis, it is always avoided. The better option would be to do a percutaneous cholecystostomy. And the fifth is gut. So there is translocation of bacteria from the gut. So it is always better to start enteral feeds, which will prevent the gut microbiota from translocating. And last is blood. So there is coagulopathy in the blood. Now, this coagulopathy in the blood can be either because of, as I told you, most of these coagulating factors are produced in the liver, So liver dysfunction can produce coagulopathy. The second is because of the burns, there is hypovolemic shock, which produces acidosis, and at this acidosis, the enzymes cannot function properly. That can also lead to coagulopathy, discussed in the shock chapter. And third is the platelets can become to less than 50,000. Now, that can also produce coagulopathy. And the fourth is there can be consumption coagulopathy. If there is a severe sepsis, that will lead to disseminated intravascular coagulation, where all the clotting factors are consumed in the blood vessel itself. So, at the site where there is bleeding, there are no coagulative factors that leads to consumption coagulopathy. And third is if a burn and is associated with a head injury. So, especially when the burn is associated with head injury, these head injury patients will lose the blood brain barrier. So, when the blood brain barrier is lost, the plasma of the blood interacts with the lipids. Lipids are in high concentration in the brain because brain needs lipids for its optimal function. So, the plasma in the blood will interact with the lipids, and this will stimulate diffuse intravascular coagulation that leads to consumption coagulopathy, and that leads to coagulopathy in general. Right? So these are all the causes for coagulopathy in a burn patient. You treat it by giving a adequate FFPs or cryoprecipitates or the factors as discussed in the chapter of shock. Right? You treat it. Now these are the complications associated with the burn, and you manage. Now how to prevent these complications? Now these complications are prevented by taking care of water, air, and food, right? So water meaning you give adequate fluid resuscitation so that there is no extra stress to the body. This is first. Second is air. As we discussed in the morning, it is you, if the criteria for the intubation is met, you intubate the patient. But intubation comes at its own risk. So try to extubate the patient as early as possible. So wean off the patient from the ventilator as early as possible. Third, you start a enteral feed as soon as possible. As soon as the gastric distension reduces, you start the patient onto the enteral feed. So it is water, air, food which help in preventing these complications. Along with that, the most important thing is wound. It cannot be emphasized any further that it is of prime importance you try to excise the wound and cover the wound as soon as possible. The best results within 48 hours. So you take care of these four things adequately: the nutrition, the fluid, the sepsis, and the wound part. You can prevent the most of the dysfunctions of this organ. Right? So this is complete about the management of the burns. The last small topic for today would be electrical burns. We'll just conclude after electrical burns and the rest of the chemical burns, the cold burns, the radiation burns, and the newer recent advances in the burns, including the dressings. We can take it up for tomorrow. So whenever there is a electrical burn, hello, is this okay, guys, or we'll take the electrical burns tomorrow only? Hello, shall we continue or conclude the class?
Continue, sir.
Okay. So we'll finish off the electrical burns. So electrical burn, as I told you, the prime difference between a thermal burn and an electrical and a chemical burn is that a thermal burn produces heat, and this heat causes a cellular damage. But an electrical burn, in addition to producing heat, can also cause a direct cellular damage. So the amount of the extent of this damage depends upon the factors. So when you look at Ohm's law, so the amount of current is directly proportional to the voltage, and it is inversely proportional to the resistance. So the more resistance a tissue offers, the less amount of the current passes through that tissue. So a skin and a bone, they offer highest resistance. Because they offer highest resistance, they are less involved. Right? The most common organ involved in a thermal burn is skin, but in electrical burn, the skin and bone is less involved because they offer highest resistance. So the amount of current it passes through them is very less. And the muscle, a vessel, and a nerve offer least resistance. Because they offer least resistance, more current passes through them. So this is about resistance. Right? This is first. Second is, we'll talk about voltage a little later, but before that, I want to tell you about a AC current and a DC current. So whatever we use, either in the household or for a transmission of the current through the lines, it is mostly an AC current. But a car battery and a lightning is a DC current, which is a direct current. So the difference is that when it is a AC current, it produces an alternating injury. This puts the muscle into continuous ongoing contractions. Like if I go and touch a wire, a live wire, my muscles in the hand get continuously contracted. There is continuous contraction of these muscles, which is a state of tetany. And the flexor muscles get more contracted compared to the extensor muscles. So if I touch, most commonly it is the upper limb that is involved. My biceps get more contracted than the triceps, so that because of these contractions, I am unable to leave the wire. So that is why a patient holds on to this wire or a source of the electricity for a longer time, because it is most of the times it is a alternating current and that produces continuous ongoing contractions. But if it is a DC current, like a lightning bolt or a car battery, so this current will cause a single strong contraction, right? So there is a single strong contraction of all muscles in the body. They get contracted, they just throw the patient away. And these patients are more likely to sustain secondary injuries, right? So this is about a AC and a DC current, and it is the low frequency, remember, not low voltage, low frequency current that produces more damage compared to a high frequency current, right? So the what we use in a household is usually a low frequency alternating current. And the third is about voltage. As I told you, the current is directly proportional to the voltage. So obviously, a high voltage causes more damage compared to a low voltage. So low voltage is what we use for domestic purposes, which is within 110 to 220 volts. And a high voltage is anything more than 500 volts, right? Which is used for transmission purposes. It can be up to 1 kilovolt or 2 kilovolts, right? This low voltage. So what happens is when the patient comes and touches a wire, now this enters the skin producing a contact point, right? So contact point, the point of entry and point of exits are, the terms are not taken now. It is the contact point that is taken into consideration now, right? So those terms are obsolete now. So there's a contact point where it enters. Then it travels through the body. It finds the path of least resistance, which is the muscle, the vessel, and the bone, right? Because direct current is inversely proportional to the resistance. Lesser the resistance, more. Then it exits from the body where it is grounded. So where the which part of the body is touching the ground, where it exits. So there is an entry point, there is an exit point, and the conduction happens. Now this can pass through any structure in the body, but most likely through the muscle, vessel, and the blood and the nerve. Sorry. If heart comes in contact, it can pass through the heart also. But a low voltage current will not produce much damage, and it is similar to that of a thermal burn. It just penetrates deep into the deep tissues, and it is not much of an issue, a low voltage. But the problem with the high voltage is it causes major damage to the muscles, to the blood vessel, and to the nerve. The muscle damage is severe, and this muscle, when it is damaged, it releases lot of myoglobin, which is a hemochromatin, right? So it results myoglobin. Myoglobin will go and it will block the glomeruli of the kidney, and that leads to AKI, right? So one is that AKI is more in these patients because of the lot of myoglobin that is released. The second reason is, even though skin is not much involved, the underlying muscle, blood vessel, and nerve are involved. So you cannot count the amount of the injury that has happened just on the total body surface area. That is why, especially in electrical injury, I told you that the fluid resuscitation has to be always 4 ml per kg because we underestimate the total body surface area. Second, you need to maintain adequate urine output of at least 2 ml per kg per hour. This is because already the urine output is less because of extensive involvement. Second is, this myoglobin is blocking the renal glomeruli and producing a obstructive nephropathy, right? Obstructive nephropathy because that is producing AKI. So that is why you need to maintain the urine output to 2 ml per kg per hour. So next is blood vessel. So blood vessel initially does not have a greater effect, but it produces a delayed effect. Right? So when the patient came to you, you debrided all the muscles, but after 2 to 3 days, you found out that this patient has got again a repeat necrosis or slough over the debrided area. This is because in these blood vessels, there is a delayed damage which will lead to the thrombosis, and because there is thrombosis, it will lead to hypoxia and again a damage to the muscles. So this muscular damage occurs in two parts. First is because the muscles are directly involved, and the second part, after a few days of debridement, again there is a slough or necrotic tissue because there is a thrombus in a vessel. And the third is nerve. So this usually has delayed presentation. It can be a central nervous system which is involved, and in the central nervous system there can be cortical demyelination, or it can lead to even hemiparesis and aphasia, or it can injure the brainstem. It can also lead to peripheral neuropathy. It can also lead to cataract, right? So the most common complication, late complication in an electrical burn injury is cataract, which can be seen up to 30% of the patients, despite the best treatment. So either it is central nervous system or the peripheral nervous system or the cataract, and of which cataract is the most common late complication. So now this high voltage produces injury by following mechanisms. One is the direct cellular damage, and whenever the resistance is offered to the current, that produces heat, and this heat will produce the thermal damage. And when this high voltage current comes in contact with the clothes catch fire, and this will again produce thermal damage. Now, in such cases, even the cutaneous burns will be more, right? A LA electrical patient coming with you with lots of cutaneous burns, it means that its clothes might have caught fire because of the resistance offered by the clothes, which convert this heat, electrical energy, into the heat, or because of the violent muscular contractions. The muscle contracts so violently that the patients can have fractures or the patients can have dislocations. And if the patient has got an electrical jolt, so if this pushes the patient away, and most of these patients are working at high altitude, that can lead to secondary mechanical injuries. So you need to be aware of all these injuries that can happen. And finally, if the current passes through the heart, there can be cardiac injury. So cardiac injury is one is either because of a cardiac muscle that is directly involved, or it is because of the electrical conducting system of the heart. The most common cardiac abnormality is atrial fibrillation, but the most common cause of death in these patients would be a ventricular fibrillation. Atrial fibrillation is more common, but it is treatable. But if the ventricular fibrillation occurs, that leads to death. So the most common cause of death would be a ventricular fibrillation, and the most common residual ECG change would be the STT changes. So this is the most common residual ECG change, and the most common late complication is a cataract seen up to 30% of the patients. So these are all the things through which a high voltage can produce an injury. So you need to monitor these patients for ECG, and if ECG is abnormal, you need to have a intensive cardiac monitoring for 24 hours. If it is not there, if it is normal, then you need not do a intensive cardiac monitoring. You can get a repeat ECG done after 24 hours. So the management of these electrical burns is same as that of a thermal burn. The only difference is being in the fluid resuscitation. I'll just elicit the differences. So the first difference in fluid resuscitation is that it is always 4 ml per kg, and the urine output has to be maintained at 2 ml per kg per hour. This is first. And second is, along with this fluid resuscitation, you need to add IV mannitol of 25 gram QID, right, 6th hourly every day, so that this will induce a diuretic effect on these patients, so that myoglobin is flushed off. Along with that, you add a 5% soda bicarb. This will also dissolve the myoglobin. So IV mannitol of 25 gram QID and 5% soda bicarb with continuous infusion. So this is a difference. And the third is you need to do early SR excision. This is same for all the patients, that early SR excision with good wound coverage is needed. And fourth is the cardiac monitoring, as discussed earlier. So these are the differences. But apart from these differences, the management of this is same as that of the management of that of a thermal burn, right? So this completes majority of the burn topic. The only thing